hemorrhage, D in polycythemia. ESR is raised in the following, or in one of the following. Which one? It's greater in men than women. B in tuberculosis. C in acute hemorrhage. And D in polycythemia. What's that? Erythrocytes and meningitis raised D? No. I can discuss this. Then why do we use ESR as a clinical practitioner? It's a marker of inflammation. We talked about it, right? When someone is having long-standing inflammatory process, long-standing infection, we can do what? ESR, and it will be raised. So which of those four do you think is a long-standing inflammatory condition? Tuberculosis, isn't it? Yeah. Okay. How far? What else did we cover last? Okay. About reticulocytes, the following are true. Or which of the following is true? About what?
Reticulocyte.
People are very good at what
Okay.
About reticulocytes, which of the following is true? A,
Hey.
they may be seen in peripheral blood. B, up to 10% of reticulocytes can be known in peripheral blood. You heard that option. C, they are the first stage of erythropoiesis. D, they are cancerous red blood cells. A, they may be seen in peripheral blood. B, they may be seen in peripheral blood up to 10%. C, what is it? They are the first stage of erythropoiesis. D, they are cancerous red blood cells. What's the answer? They are found in peripheral blood, right? I told you what level of reticulocytes are normally seen in peripheral blood. Who remembers? Less than 2%. Yes, less than 2%. Okay. About erythropoiesis, which one is true? Only mature red blood cells are released in peripheral blood. And then which one is true? A, only mature red blood cells are released in peripheral blood. Sounds better. B, B is about erythropoiesis. Iron and vitamin B12 are not always needed for erythropoiesis.
They are needed.
C, iron is a maturation factor. D, folate is a
Ferritin.
maturation factor.
This is why you mentioned
Which one?
ferritin. That one, the carrier of iron.
Okay, we said A was what?
mature red blood cells are.
Yes, what's the answer? A was not correct. Okay, from the others, what do you think is the correct answer? C was iron is a maturation factor. Hello? No. Yes, so which one is the maturation factor? Iron or vitamin B12? Vitamin B12 is it? So vitamin, we said folate is the maturation factor, isn't it? What's the function of iron? Yes. Okay. So what's the function of iron in the production of red blood cells? Yes, it's where oxygen moves. Yeah. So it helps in the formation of hemoglobin. Isn't it? So it's a substrate that's here to form hemoglobin. Right. That's its role in erythropoiesis. Okay. Hello. Okay, so since you can hear me now, I probably won't have to keep moving around, isn't it? Yeah. Okay. So today's tutorial will focus on we ended on red blood cells erythropoiesis last week, isn't it? So now we are going to go into a little more detail, talk about what we call red blood cell indices, okay? And we're going to talk about a very interesting concept called blood grouping, okay? So that's what today's tutorial will do. So, what do you think are red blood cell indices? Okay, an index is some sort of a measure of something, isn't it? Now, when we talk about red blood cells, okay, we not only are interested in knowing, okay, what's the red cell count in someone, what is the hemoglobin, we want to know what is the quality of these red blood cells, okay? And that is where we come to this discussion of red blood cell indices. So essentially, they are basically a measure of the size of these red blood cells, the hemoglobin content, the hemoglobin concentration, okay? And what we deduce from your red blood cell indices is if there's a variation in your red blood cell indices, okay, maybe we see that these red cells are smaller than they are supposed to be. They have a less hemoglobin content, for example. Then that should tell us, it gives us a good indicator of what the possible causes of this is. You get my point? Simply looking at the low HB won't tell you much about what could be causing it, isn't it? But if you understand your red blood cell indices, it will give you a good idea of what could be causing this. Okay, so that's what we use red cell indices for. Okay, so before we go into red cell indices, at second, third year level physiology, you not only need to know about red cell indices, you need to know how to calculate these red cell indices. Okay. The question was given to your fourth years right now. Calculating red cell indices. They felt that, okay, because they didn't try to understand how these things are calculated. Okay. Very few people pass. Okay. So you should expect to know these calculations. So we start by recalling what packed cell volume is. Anyone to tell us what packed cell volume or hematocrit is? You remember we talked quite extensively about it last time. Remember it's a tutorial, hybrid lecture, but we still have to know. Yes, what is packed cell volume? Yeah, so it's basically a fraction of blood that has your red cells, isn't it? And remember that this can also be called your hematocrit. Now, this hematocrit is normally it normally ranges from around 38 to 47%, with an average of 45. Okay, so that's your normal packed cell volume. We talked about different conditions which will raise your packed cell volume, which will drop your packed cell volume, and so that. Now, when we talk about red cell indices, we have four red cell indices. Does anyone know what these four red cell indices are? The first one is already on the board. It's the color index. Okay. The other one is size. Now, what is the index that tells you about the size? It's called MCV, mean corpuscular volume. Okay. What's the other one? Remember that we said that the indices also check for hemoglobin content, isn't it? So the other one will be mean corpuscular hemoglobin. And we say they also talk about hemoglobin concentration, and that will then become your mean corpuscular hemoglobin concentration. Okay, so those are your four facts, four red cell indices. Color index, MCV, MCH, MCHC. Okay, now color index is a very, it's an outdated red cell index. We don't even use it anymore. Okay, because it's very, doesn't correlate well with the true blood picture. However, we'll still talk about it very quickly. Essentially, it's a ratio of how much hemoglobin do I have compared to what I'm normally supposed to have, divided by what is my red cell count compared to the normal red cell count. Okay, so let's say my hemoglobin I measured it's 8. Okay, and let's say for example the average normal you're using is 14. Okay, so what you're going to put on top is 8 over 14 divided by your red cell count. Let's say my red cell count is 3.1. Okay, and the normal will take it as let's take the normal as 5, for example. So you're going to do 3.1 over 5, and what you're going to calculate is the color index. Okay, essentially it's just a ratio of what your what your hemoglobin and red cell count are compared to what a normal is supposed to be. Okay, and remember if it's normal, then this ratio is supposed to be 1. Okay, so accepted variations will lie between 0.8 to 1.2, okay, or 0.85 to 1.15, okay, and that's your normal color index. But remember, it's not a very good marker, okay, so we don't even use it clinically. What we use is MCV, MCH, and MCHC. Now, mean corpuscular volume. This essentially it tells you what is the average volume of these red cells that you have. Okay, so are they normal volume? Are they smaller than normal? Are they larger than normal? Okay, that is what your MCV will tell you. Now, this is a very important marker, very, very important for you to understand. Based on this, we classify our anemias as microcytic or macrocytic. Okay, microcytic being those conditions where you have an MCV less than normal. Macrocytic, a condition where you have an MCV greater than normal. Okay, how do you calculate it? The formula has been given there. So it's your packed cell volume or your packed cells, number of packed cells per liter. Okay, so let's say that someone has a packed cell volume of 45%. Okay, so crudely you could say that there are 45 cells, or the packed cell volume per 100 is 45, isn't it? So what is it going to be per 1,000? It's going to be 450. So you put it per liter over there. Okay. So if someone gives you a hematocrit of 45, so what you simply do is you do hematocrit times 10. Okay. So that's going to be your PCV per liter. And then you get your red cell volume in cubic millimeters. Okay. And you're going to divide them to get your MC. Now remember, look at the units there. You're going to convert your final answer in cubic microns. Okay. The normal MCV is 78 to 90. Okay. And anything lower is going to be what we call a microcytic picture. Anything higher is going to be what? A macrocytic picture. Okay. Mean corpuscular hemoglobin. Now this tells you about the hemoglobin of a red cell, right? Irrespective of the volume. Okay. So how we calculate it again is your HB content per liter. And you remember that HB is reported per liter. Remember, I mean it's reported in deciliters. So you're going to convert it to liters, right? We get grams per liter. So we convert that to liters. Don't worry about this when we have a revision session. I'm going to take you through these calculations. Okay. For now, I just want you to understand what these things are and what they signify. And divided by your red cell count in cubic millimeters. So essentially, it's one and the same thing. It's the same thing as mean corpuscular volume. In your mean corpuscular volume, you are doing your packed cell volume divided by red cell count. In your MCH, you are doing your hemoglobin content divided by your red cell count. Okay, so it will tell you what's the average content of hemoglobin in these red cells that we have. It makes sense, right? So you're dividing what your hemoglobin is by all the red cells that you have. So that will give you like an average of what one red cell has, isn't it? It normally varies between 28 to 31 picograms or hemoglobin per cell. Then you have your MCHC. So this one, apart from, it's a sort of better version of MCH. MCH tells you the content, okay, irrespective of the volume. MCHC will take into consideration the volume of your red cells, okay. So it's not going to give you your HB content in a red cell as a concentration, okay. So by taking into account the volume. So how you calculate it is your hemoglobin in grams divided by 800. Okay. Right? Normally between 30 to 38. Now, the significance of these red cell indices, as I told you, it helps us in classifying the type of anemia that someone can have. Okay, so based on the MCV and MCA, we can classify these anemia. Now, let's say someone has anemia. Remember, anemia simply is a reduced red cell count, reduced HB, or reduced hematocrit. Now, we use these to further qualify this anemia that we have. If someone has a normal MCV and a normal MCH, that is what we are going to call a normocytic normochromic anemia. Okay? And there will be certain causes that are related to it. Okay? Now, you must understand, why do you think in someone that's anemic, that is, why do you think these red cells will start becoming smaller, will start having less hemoglobin? Where do you think the problem must lie? If someone has anemia, okay, and you see that the red cell count has started, I mean, the cells have become smaller, the hemoglobin content has reduced, generally, where do you think the problem must be? It's where they are coming from, isn't it? So in the bone marrow, isn't it? So there must be one problem or another in the bone marrow. So what do you think could be a cause of, let's say, a normocytic normochromic anemia? If while walking here, I fall down, I fracture my femur, I lose 2 liters of blood, I'm going to be anemic, right? We agree. I'm going to be anemic, isn't it? I've lost blood. At the same time, you do my red cell indices, okay? How do you think my red cell will look? How do you think they'll appear? Do you think they'll be smaller? Do you think they'll have less hemoglobin content? No, right? They'll simply be the way they are. There's no problem with my production of red cells, isn't it? So acute hemorrhage is a cause of normocytic normochromic anemia. Okay. Now let's flip that question another way. Let's say I have a cancer, okay, in my colon, okay, and because of this cancer, I've been bleeding, I've been losing blood for maybe 5-6 months, okay, chronic hemorrhage. Now, do you think I'll still have normocytic normochromic anemia? No, right? So let's move on. We'll come back to our example. Now, in a case where you have a normal MCV, we're going to call it a normocytic, with a reduced MCH, it's going to be hypochromic. Okay, normocytic hypochromic anemia. If you have an increased MCV with a reduced MCH, we're going to call that a macrocytic hypochromic anemia. And then finally, with a reduced MCV and reduced MCH, we're going to have microcytic hypochromic. Okay, hyperchromic anemia, so it's not an entity that we'll really focus on because it's essentially very, very rare for us to have raised MCH truly because of increased hemoglobin content. Okay, so just focus on this. Now, let's talk about some causes, which so that we can put this into perspective. So I was saying, let's say I have been bleeding for a long time. Well, let's say a woman, okay, she has been having excessive menstruation. Okay, she's been losing a lot of blood. Okay,
we all agree, number one, that she won't have a normocytic hemochromic anemia, isn't it? We agree. Okay. What's going to happen now is that, you see, when you lose blood over a long period of time, the the primary problem that you're going to suffer from is what? Iron deficiency. Okay, because you lose iron at a rate much faster than you can replace. You understand? Okay, and we're saying that iron was necessary for what? For what? Hemoglobin formation. And we do remember that hemoglobin is what gives the color to our red blood cells, isn't it?
Mm.
We agree? Yes. So this person is someone who is going to get a hypochromic anemia. Okay? We agree. We agree, right? Hypochromic anemia. Someone chronic blood loss. These people get hypochromic anemia. And we're saying that the reason behind this hypochromic anemia is what? Iron deficiency. Okay. Now, what do you think is going to happen to the red cell size? To someone who is chronically losing blood. Okay? Meaning we've talked about what's going to happen to the MCH, isn't it? It's going to be hypochromic. What about the MCV? It will be initially normal, okay? It may initially be normal. But where this person will progress to is because of this long-standing reduction in hemoglobin concentration, hemoglobin production, the red cells will keep reducing in size. Okay? We understand that the red cells will keep reducing in size. Hence, iron deficiency anemias will classically give you what? A microcytic hypochromic anemia. Understood? So anything that will cause iron deficiency, such as chronic blood loss, such as maybe someone has a cancer, they are losing blood through that, a woman has been excessively menstruating, let's say you have a hookworm infection, these hookworms are just sucking blood out of you. Okay? All these will lead to iron deficiency anemia, which will lead to a microcytic picture. We understand? Okay. Now, what about macrocytic picture? What do you think would cause a macrocytic picture? And I think I actually mentioned this in the previous episode. Let's try and put this into perspective, because when you put these things into understanding what type of anemia will come about, what will happen to the size of the red cells, it becomes easier for you to understand what the function of those things that are deficient are. Isn't it? So let's say you have someone who has a B12 deficiency, okay? And we talked about how you can get a B12 deficiency. I hope you remember, right? Okay, you remember. So the B12 deficiency, someone has a B12 deficiency, and we're saying that B12 is a what? What type of factor is it? Maturation factor, isn't it? And we say that what is the essence of maturation factors? What do they do in erythropoiesis? They allow for DNA synthesis, right? And DNA synthesis is important for red cells to continually divide through those cycles of erythropoiesis to finally become a mature red blood cell, isn't it? So, if someone is deficient or is vitamin B12 deficient, that red cell division will be impaired, isn't it? And that impaired red cell division will lead to the red cells being very large, even at the end of erythropoiesis, isn't it? Hence, what you will see in peripheral blood is a macrocytic anemia, isn't it? There will be reduced production of red cells, hence there will be anemia. However, what will happen is that these red cells will be enlarged, isn't it? And that's what we call a macrocytic anemia. So things such as B12 deficiency, folate deficiency are what are going to cause macrocytic hypochromic anemia. Understood? So I put an example over here. So, forget about the color index, we don't concentrate on it. MCH, I don't know, I think because of the screen showing it inverted, but MCH of 75, which is normal, right? MCV of 20, which is reduced. MCHC of 26.7, which is also reduced. What type of anemia is this? Reduced MCV, reduced MCH. Okay, reduced MCV, is it macrocytic or microcytic? Microcytic. Reduced MCHC, is that hypochromic, normochromic? Hypochromic, isn't it? So it's a microcytic hypochromic anemia. You understand? Okay. So that was the end of red cell indices. Now we talk about your white blood cells. Now, this slide was sort of was supposed to look at the ABO grouping before that. We actually just so that we can sort of flow in one direction. So essentially, at the end of this, then we'll finish discussing red cells. Okay, so the last aspect when we talk about red blood cells is the blood grouping system. Okay, and the most important blood grouping system that we have is the ABO system, right? How many of us know their blood group? Okay. What's your blood group? No. O positive. Okay. Who else wants to tell us their blood group? You say you know it. What is it? B positive. Okay. So anyone else that has a blood group other than O positive and O positive as well? Anyone else who has a blood group apart from O positive or B positive? Yes? A positive. Okay. Anyone with something negative? Blood group. Yes? O negative, we have a universal donor. Okay. So, if you guys, when you are in your clinical years, someone that has lost blood, what's your name? What's your name, doc? Sorry? Marjorie. Okay. I can't really hear your name. I don't want to mispronounce it. Okay. When you guys if you are going somewhere for CBE or someone has lost blood and you need to transfuse, you don't know their blood type, grab that woman and transfuse because she's a universal donor. Okay. Or negative. Right. Okay. Right. Okay. So, talking about the ABO system. Now, this system is essentially made up of a group of markers that are found in the red blood cell. Okay. These markers are either A or B, and they are all what? Antigens. Okay. And the counterparts of these antigens are antibodies which are found in your plasma. Okay. And this mix of your antigens with whatever antibodies you have is what's going to determine your blood group according to the ABO system. So our doctor over there says she's blood group B. Okay. So which antigen does she have on her red cell? Which one do you have? Yes, she has B, the antigen B, isn't it? Then which antibody does she have in her plasma?
Anti-A.
Anti-A. Understood? Okay? Down there you have blood group O, same as our universal donor. Okay? So which antigen does she have on her red cells? She has none, isn't it? She neither has antigen A or antigen B. But what antibodies does she have in her plasma?
Yes,
Anti-A, anti-B. Okay, so that's the idea. This blood group system, using these combinations, we're going to make up 4 types. Okay, blood group A, blood group B, blood group O, and blood group AB. So, A, forget the genotype for now. Remember, we're simply looking at the phenotype, what is expressed on the cell. Blood group A will have antigen A on the cells, and the antibody in your plasma or serum will be anti-B. Okay, B will have antigen B and anti-B in their serum. AB will have both A and B antigens on their red cells with no antibodies in plasma. Okay, because obviously if there's if they are antibodies to plasma, they may start attacking their red cells. Okay, that's why you have the opposite antibody. Okay, and then blood group O who have no antigens on their cells but both antibodies on in their blood. So we'll talk about the inheritance soon. So yes, now we've talked about the antigens. Now the antibodies. These are very special types of antibodies in that they are natural antibodies. The moment you have blood group A, okay, your body will naturally develop anti-B in serum. Okay, so the antibodies of antigen A and anti-B are naturally occurring antibodies. Okay, you understood that? Sorry, you understood, right? And this follows this law called the Landsteiner law, saying that if a particular, okay, I actually asked one of you to repeat so that maybe it sticks in your head. So, just read it.
Okay, it reads, if a particular antigen, in brackets antigen, is present in the RBCs, corresponding agglutinin antibody must be absent in the serum.
Okay, so that tells us that it's saying if you have antigen A in your on your red blood cell, you cannot have anti-A in serum. That's what the first one says, isn't it?
Then two, if a particular antigen is absent in the RBCs, the corresponding agglutinin must be present in the serum.
Okay, and that tells us that within the ABO system, the antigen that you don't have in plasma on your red cell is whose antibody will be found in serum, right? So this dictates how your A and B and O blood grouping system works. Okay, now this second part of the Landsteiner law saying that if a particular agglutinogen, meaning the antigen, is absent on your red blood cells, the corresponding agglutinin or the corresponding antibody must be present in serum. This does not apply to the Rhesus factor system. Okay, what's the Rhesus factor system? Yes, that's the positive and negative we are talking about. Okay, so this Rhesus factor, how it came about is that a group of scientists, well, they discovered the ABO system. Okay, then they thought, okay, it's just ABO, so meaning if I'm A, I can get A, isn't it? But then they found that in a particular group of individuals, there were still massive transfusion reactions. Okay, things that you're not supposed to expect if an A gives an A. You get my point? So the question was, why is this happening? Okay, that's when a number of other blood group systems were devised, and they found that in as much as many of them are insignificant, there is one particular one, which we found in a monkey called the Rhesus monkey, which we also have. And it seems to be the one which is causing this transfusion reaction. And that's why it was called the Rhesus factor. Okay, we'll talk about this factor and come back to this soon. So yeah, let's talk about how your ABO system is inherited. Okay, so for someone to have blood group A, remember that there are two alleles which will code for this antigen, right? One on each chromosome. Okay, one maternal and one paternal chromosome. So if you have a phenotype of A, meaning you are expressing antigen A on your body, on your red cell, okay, it could mean two things. Okay, either your alleles are homogeneous, meaning you have from your mother A or from your father A, okay, or your mother A, your father O, you still express antigen A. Okay, so what we are saying is that the allele for antigen A and the allele for antigen B is dominant. Okay, over, that's O, meaning over not having one to express for. So A can have a genotype of AA or AO, B will have BB or BO. AB will arise in a system where my father gives me A, my mother gives me B, and I'll express antigen, both antigens, because they are codominant. Okay, A and B are codominant. Neither one of the two is dominant over the other. Okay? And then your blood group O will arise in a case where both your parents will give you O and O. So we understand how we inherit these, okay? So you might be BB, okay? So you're homogeneous B, or you might be heterogeneous, where probably your father gave you an O and your mother gave you a B, and you express B, right? So it's one of the two. Okay. Okay, we talked about this, the Rhesus blood grouping system. Now, this Rhesus blood grouping system is made up of a number of antigens that we name from C, small c, D, E, and small e. Okay, there are a number of antigens. Now, amongst these Rhesus groups, the one which is very strongly antigenic is your antigen D. Okay, and it is based on the presence or absence of this antigen D that we determine whether one is Rhesus positive, right? Rhesus positive means that they have antigen D on their red cell, okay? Or they are Rhesus negative, being a case when, like her, she does not express the Rhesus factor, isn't it? So the Rhesus factor is antigen D. Okay, now, when we talk about this Landsteiner law, the second part not being applicable to the Rhesus, the Rhesus system, what are we really talking about? Maybe the person who doesn't have antigen D knows, isn't it? No, you are O negative. What does this statement mean with respect to you? The second part of the Landsteiner law doesn't apply to those who do not have the Rhesus factor. What are you trying to say? Okay. Anyone to explain on her behalf, tell her what's happening in her body. Okay, I'll put the question. Maybe you're not understanding my question. My bad. Does she have anti-D antibodies? We said she doesn't have antigen D, isn't it? We agree. That's why she's telling us she's O negative, isn't it? But does she have anti-D antibodies in her plasma right now? Why? Yes, it doesn't apply, isn't it? So anti-D antibodies are not naturally occurring antibodies. You get my point? The body will only make these antibodies if it is stimulated to make them. Understood? So an O negative or a Rhesus negative individual will make these Rhesus antibodies in a case where they are exposed to Rhesus positive blood. Isn't it? All along, they've been fine. They don't know about Rhesus. Okay? So her relatives don't know about Rhesus. Okay? Then all of a sudden, she's exposed to this red blood cell that has antigen D on it. And the body will surprise. What's this? Now it's going to start making anti-D antibodies. Okay? So they do not occur naturally. So let's talk about the inheritance of your Rhesus factor. Now, the Rhesus factor is also and by Rhesus factor I'm talking about antigen D. Okay, the Rhesus factor is also a dominant allele. So in a case where, let's say, your father, meaning, okay, for someone to be Rhesus positive, it could mean two things, isn't it? Either they are homogeneous DD, meaning capital D, or they are heterogeneous D and small d, isn't it? Right. For someone to be have a phenotype of Rhesus negative, that means they have what? Homogeneous recessive, small d, So the inheritance is pretty much the same as your ABO system. Okay. So someone, let's say father and mother, or father is rhesus positive, mother is rhesus negative. Okay. Capital D for the father, so meaning is homogeneous, dominant. You'll see that all children will become heterogeneous, but they'll still be rhesus positive, isn't it? So in a case where a father and mother are both homogeneous recessive, meaning rhesus negative, they are going to be homogeneous, homogeneous recessive or negative. Okay. Maybe no. Do you know any of your parents' blood groups?
Yeah, my dad is
Negative.
and then my mom is I don't know.
She's what? She's A. There is no A, all right? Well, what's her rhesus factor?
I have no idea.
Okay, so we can already see, right? Her father is rhesus negative, isn't it? So we can see where it's coming from. That means that means two things. Her mother, if she's rhesus positive, do you think she's homogeneous, dominant? No, she must be heterogeneous. Right? So it only means two things. If her mother is positive, she must be heterogeneous, dominant, or she must be negative. Right? Your siblings. And I hope you don't mind me. It's just to help us understand. Do you know their blood groups? Or your siblings? Oh, nice. So she's O negative as well, right? Any other sibling that is, or anyone with a positive amongst the siblings? And how many are you? Sorry? Okay. Right. So she's saying that we are simply trying to put this into perspective, okay? And let's calm down. So she's saying that she's got a number of siblings, okay? And none of them are positive, okay? None of them are rhesus positive. They're all negative, okay? Now, that tells us that she's probably her mother is also rhesus negative, right? Because you see the chance, even if her mother was actually rhesus positive with a heterogeneous allele, we'll see that at least half of her siblings would be rhesus positive. You get my point, huh? But in the case where most of the siblings are actually rhesus negative, and she has a number of them, so we can remove the factor of chance. Well, what do I think say that her mother is probably, rhesus negative as well? So you understand the genetics, right? Okay. So, anyway, this is just a background behind your research factor, but I think I've talked about it. Now, the production of immune antibodies, the anti-D, is going to occur after someone is sensitized. Okay? So what we're saying is that on the first exposure, what's going to happen is, and probably you will learn about this. Have you started learning immunology? Yes. Yeah. Or I'll talk about why the positives are happy and the negatives are not happy. But doesn't mean that if your research negative you must be sad. There is a reason why. Yeah. You must be very happy because you can say like, okay, I'll explain why this book where I got this picture put aside. Okay. Yeah, so we're saying that you said you started learning immunology, right? Have you learned about B cells?
Yes.
The topic on B cells and how B cells work, primary immune response, secondary immune response. You learned about that.
Yes.
Okay, so which one is the antibody of the primary immune response?
This
Which one is the antibody of the primary immune response? You know this.
IGH.
IgM, right? And which one is the antibody of the secondary immune response? Or the sustained immune response? IgG, isn't it? So, this was going to happen. And it's good that you learned it so that we can put this into perspective. Let's say someone is O negative. Okay? I'm O negative, I get transfused I get O positive blood, for example. Okay, although it cannot happen in the advances we have made in transfusion medicine now, but probably that's a hypothetical scenario. Okay, I'm O negative, I receive O positive blood. The MBO system is okay, but the positive and negative are incompatible. So what's going to happen is that my body, who has never seen a D antigen, is going to become sensitized. Okay, I'm going to become ready to now produce antibody D, isn't it? So in the initial immune response, I'm going to produce which type of antibody D? Antibody D. Which immunoglobulin will I produce? IgM, isn't it? Because it's the primary immune response. And remember, in the primary immune response, there are two things that happen. I'm going to produce an antibody, but at the same time, I'm going to produce a group of cells called memory cells. Okay, and these are now going to remember what has happened to me. Okay? So my IgM, remember, is a primary immune response. IgM doesn't have a long half-life. It will go up within a matter of 2-3 weeks. Things will be okay. Okay? Another time, I'm in a road traffic accident. I've lost blood. Now someone wants to give me O positive. Okay? That's signing my death certificate. Okay? Because now I have this group of cells called memory cells made specifically for anti-D. They are waiting for another antigen D to come so they show what they can do. The moment I receive antigen D, I'm going to now start a massive secondary immune response, which is going to be IgG. IgG will go and knock my kidneys out, is going to go and knock all the blood that I've received, is going to go and hit my brain, hit my heart, and someone will end up dying potentially. Okay, a massive transfusion reaction. Okay, so what we're trying to say is that the initial exposure will cause sensitization. The second exposure is what's going to cause the actual problem. Okay, so then that brings us to putting this into a nice example called hemolytic disease of the newborn. Anyone heard of hemolytic disease of the newborn? Explain to us what happens here. It's essentially the same thing that I've talked about. Okay. Anyone to help us? What is hemolytic disease? So this is where these smiley faces will come around. So let me go back. So let's say you have a mother who is Rhesus negative. Remember, the mother needs to be Rhesus negative for hemolytic disease of the newborn. So if you apply to, let's talk about this scenario here. Mother Rhesus negative, father Rhesus positive but heterogeneous. Okay, what's going to happen now is that half of the siblings will be Rhesus negative. I mean, half of the fetuses will be Rhesus negative. Okay, in this pregnant mother. The other half will be Rhesus positive. This Rhesus negative. Let's say that the child is Rhesus positive. Okay, the child is what? Rhesus positive. This mother is Rhesus negative. Let's say during the first delivery, the first child is Rhesus negative, Rhesus positive. While they are delivering the baby, they cut the umbilical cord. There will be mixing of fetal and maternal blood, isn't it? So the mother is now having a taste of what? Rhesus positive blood, isn't it? What's going to happen is that the mother is now going to become sensitized. She'll deliver, the first baby will be fine, no problem, isn't it? But the mother is now sensitized. Come the second pregnancy. The second pregnancy, this child is what? Rhesus negative. Okay? The mother is Rhesus negative as well. What's going to happen is that this mother who is sensitized has the potential to produce anti-D antibodies, isn't it? And this time around, what type of antibodies will be produced? IgG, secondary immune response. And what's that special about IgG? It can cross the placenta, isn't it? Okay, so here are anti-D antibodies, okay? Which will now go and attack the fetus with red blood cells. okay, and end up with what we call hemolytic disease of the newborn. Okay, so that's why your D have sad faces, your Rhesus negative. Okay, but it's just with respect to this. Remember, AB is O negative is still the universal blood donor, and we cherish these people. Okay. I won't dwell so much into how to deal with research. You can read it up in your own time. Okay, here. So you see that first transfusion from Rh positive to Rh negative. There are no complications, right? But the R, yes, sir.
The example you gave for the fetus and the mother being both Rhesus negative,
Yeah.
the antibodies are still going to attack the Rhesus negative fetus.
Come again?
Are the antibodies, the anti-D,
Yes, anti-B.
are they still going to attack the Rhesus negative?
No, they attack a Rhesus positive. Remember, you need to have the antigen on the red cell, right? So the problem will be when the fetus is Rhesus positive now. You get my point? Yeah. So you transfuse. Basically, we talked about this. The first transfusion, there will be no complications, but the mother will be sensitized. Okay, you produce Rh antibodies, but in the second transfusion is when the problem is going to come about, and you get agglutination. What is agglutination? What is agglutination?
Compatibility.
Okay, so essentially it's clumping together of red cells, okay, because of this antibody which is able to bind to the antigen, okay, and it's able to bind multiple red blood cells, so they'll start clumping together. That's what we call agglutination. So it's a feature of the transfusion reaction. Okay, then apart from your Rhesus and your ABO system, there are a number of other blood grouping systems. The M and N factors, there are a lot, okay? But none of these produce clinically significant transfusion problems, okay? Hence, we don't consider them. The two main ones are ABO system and your Rhesus factor. Okay, so blood transfusion. Remember that how many of us have donated blood before or have received blood? Luckily, no one has received blood. But how many donate blood? It's good to donate blood. Okay. Very good to donate blood. You'll be saving a life, and blood donation is actually shown to be healthy for you as an individual, right? Because you're stimulating your body to produce new cells. Isn't it? So it's very good. Okay, so blood transfusion, remember, you can transfuse either whole blood, you can transfuse either a component of blood, but we are going to talk about this whole blood transfusion. So you can transfuse to save someone who has had a massive blood loss, someone who is in shock, severe anemia. Those are some of the reasons why you may want to transfuse someone. Now, you need to be very cautious when you are transfusing blood. Firstly, you need to know, isn't it? You need to know the blood type of these individuals. Okay? And that people with an A who can either receive from an A or they can receive from an O. Isn't it? Why is it that they can receive from an O? Why is O a universal pronoun? Yes. So how I like to think about this is, let's say my body or my blood is a house, okay? And then the antigens are us, the people living in this house, and then the antibodies are dogs, okay? That are guarding this house. So now, it's funny, but that's how I always remember this. Okay? The antibody is a dog, okay? And it's a dog named B, antibody B. Okay? So now, if I receive a visitor who is carrying B on itself, okay, this dog will recognize that visitor and will attack. Okay, that's why A, who has anti-B, cannot receive that group B. You get my point? Because the visitor will be carrying B and the dog will recognize it. But A can receive from A, isn't it? Because the antigen, the antibody is what? B. and the visitor will be carrying a marker called A. So they won't recognize it. You easily enter my house. Isn't it? What about O? Yes. Yeah. Yeah. So yeah, I was going to come to that. But let me just explain what I was saying. And I'll come to what you're saying. So let's say now O comes. Okay, I'm receiving blood with O. So this is someone who's not carrying any marker. The dog won't mind anything. Okay, you can enter. Now the question that your colleague has posed is something that troubled me for a long time. But okay, O will come in, right? But what O carry its own dogs, A and B. So what they attack the owners of the house, isn't it? So we understand the question, right? But the idea they the donor produce a very transfusion reaction. It has been they produce a very minimal transfusion reaction, which is almost insignificant. Okay, so those antibodies don't tend to attack the recipient's red blood cells. Okay, so that's the idea behind when we are talking about who can receive blood. Now, we've talked about the universal donor. What about the universal recipient? The universal recipient is a house that has both A and B and doesn't keep any dogs. Okay, so any beef can enter this house, isn't it? So they can receive from anyone. Okay, yes. Now, to come back to his question, because there is still this issue of there are numerous other blood grouping systems, isn't it? And there may sometimes be a clinically significant reaction when you transfuse even compatible blood groups. That is why we do what we call cross-matching. Okay, cross-matching means even if I'm A positive, I'm receiving from A positive, we don't just give blood like that. You need to get a bit of the donor blood, you need to get a bit of the recipient blood, you mix it. See, is there any reaction happening? I'll cross-match, isn't it? We get the idea of cross-matching, right? Then you say, okay, there's nothing happening, then now let's give this person this blood. Okay, so cross-matching helps to eliminate any minor blood transfusion reactions that may happen even in compatible blood groups. Okay, so of course, remember when you're transfusing blood, you need to make sure that there's no infection, so it's screened for various infections. Okay? And if you've donated blood, there's actually a questionnaire that you fill in. Okay, what's your HIV status? When last did you have any fever? When last did you test for hepatitis? Are you on any drugs? Did you consume marijuana in the past 72 hours? You can't say that. Okay, so there's a screen. Huh? So, you see, marijuana has its own medical effects. So, if marijuana is present in blood that you are donating, you may cause adverse reaction because of the isn't it? So, there's something wrong with it. It's a no. What do you mean it's not effective? Yes, it may have its effects on you. You get my point? But we are trying to give the safest blood possible to someone who's receiving blood. You get my point? So there's everything wrong.
How long does cross-matching take? And if there's an emergency, like someone really needed the blood just then, do you still cross-match or you can just?
Yes, so that's what I'm saying, that if someone needs blood right there and then, we transfuse O negative. Okay. O negative, the assumption is that this is a person who can give anyone blood, isn't it? He does not have any antigens, either A, B, or D. You get my point? Cross-matching takes at least 4 to 6 hours in our blood banks. But in case of in case you can't wait to cross-match, you will give O negative, which is the universal donor. get my point? Okay, so that was your, and then there are some of these hazards of blood transfusion reactions. You can read about them if you want. Yes.
21.
Yeah. So how the blood bank works is that they screen your blood when they collect it, and then you can very easily go for a report and everything is screened. That's why it's good to donate blood. Because essentially now you're checking yourself. And because you want to donate blood, you're going to make sure that I'm not going to have unprotected sex, I'm not going to do these risky behaviors such as IV drug use. Yeah. Yes, Doc. Oh, by the way, sorry. We've come to the end of the blood grouping before we go to white cells. So we can take that small refresher for 5 to 10 minutes. Yes. But let's maintain size. I can't hear your question. Does blood donation have an effect on what? Sorry, yes. Let me come closer. Does blood donation have what? Blood cell indices. Ah, no. Blood donation, you are giving normal. You get my point. Shouldn't have any. Yes. No, it's not true. The only thing that we think they have, kind of disease that is at the time when you want to draw from. You get my point? Yes. No, it does not. You're simply getting 450 mils of blood. Yes, we don't, it's 450 mils, isn't it? 450 mils of blood. Okay. Oh, sorry, yes, sir. Yes. Okay, it would mean that one of the friends of the protein, right there, because we're moving to that way, there's a 50% chance. Yeah, exactly. What causes what? Blood poison. So I think what causes blood poisoning? Yeah. Yes. So blood poisoning, whatever poison they may be, there are various toxins that may have poison. So we call them toxins, right? So it depends. There are various poisons or toxins that and what you're talking about, what they need is a procedure called plasmapheresis. Okay, exchange transfusion. So this is blood transfusion. So it's one-way transfusion. You're just giving something. Now, exchange transfusion is where you are getting something out and you are putting something else in at the same time. And that's probably what plasmapheresis is. very nice, sophisticated machine that will do that. And even filter out the toxin completely from blood. Yes. Hemolytic disease of the newborn. Babies do not want what? Blue. No, hemolytic disease of the newborn is not cause cyanosis. So what are we talking about? So there are cyanotic diseases in children, but hemolytic disease, this will be a child that will be born anemic, it will be born with heart failure, so it will be born swollen up, and that's why it's also called erythroblastosis fetalis, hydrops fetalis, because the child looks swollen up. Yeah, but it's not the cause of cyanosis. Yeah, so it's like cyanosis, we talk about when you do respiratory physiology, it's due to impairment of oxygenation of blood. Okay, it's not really due to oxygenation of blood is not affected in this case. Yeah. All the okay, but majority of them, 85% of people will have the rhesus factor. Okay, so only 15%. So if you do like 15% of 47, will be a good amount of people that are putting. Yes, doctor. People like blood transfusion. Sorry. You are getting marijuana in that
I think I'll smoke that.
someone blood has marijuana. You are getting blood from this person. So you're getting a bit of that.
Dindi alisendero kuwa nanka.
You are giving them marijuana, which will then have its own effects.
When you smoke,
Where else are you
does
putting
it
that
just
blood?
go in the lungs? Does it also go in the bloodstream? Ah,
How does it
Ah.
go to your brain?
Because and
How
how
does
does it
how
how
do
does
you
it enter the
when you consume alcohol, and you feel that lightheadedness because alcohol mimics the barbiturates receptor, works on the GABA receptors in your brain. How does it get to that GABA receptor?
On the
Through blood.
front of one, there is a
It's
space
present in your blood, so
which
your
is used
blood
for
constantly
with
has
air.
alcohol,
Also
which is
air and
constantly flushing that
so
GABA
I
receptor with
think when you smoke, there's a
alcohol over and
possibility
over.
to
It's not that it goes
it's not
and
I think diffusion.
you get
Diffusion.
You get
Because blood goes to the lungs and through the whole yeah. So there is a possibility of it
There is a
coming.
possibility.
And then it can have an effect.
I'm not sure. I don't remember the half-life.
Yeah.
When something goes to your brain, I don't think you don't take it as it's in your blood, which is supplying your brain. That's just someone with A positive give blood to someone. No, because you know you are going to sensitize the person's treatment. Isn't it? So in the initial transfusion, nothing will happen, right? But the moment that person receives positive blood again. Okay, let's move on. One more question, yes. Yes. Yes, it can. Very easy. Yeah. So that child was born with a condition we call hydrocephalus. Now, hemolytic disease of the newborn doesn't cause hydrocephalus. I may not be able to say because probably I didn't see the data. It does cause hydrocephalus. You get my point. Probably that hydrocephalus is really what caused by something else. Okay? But what these children will present with, they will be swollen throughout. Okay? It will be a very swollen baby because the heart is big. Okay? There will be jaundice here, so there will be jaundice. So probably, yeah. But it then was hydrocephalus. Okay. We can move. Okay. So white blood cells. How much time do we have? Okay, we'll be done. So remember, white blood cells. Now these are one other arm of your formed elements. They are larger than your red blood cells. Okay, averaging around 5 micrometers in size. They do contain the nucleus, and they do not contain hemoglobin. And these white cells generally, their function is defense, right? So they form the immune system of the body. Okay, the normal white cell count ranges between 4 to 11. Other references will say 4 to 10. Okay. Now, when we look at these red blood cells, white blood cells, sorry, we can grossly classify them into two, right? What are the two broad categories of white blood cells?
Good.
Granulocytes and agranulocytes. Which ones are the granulocytes? Neutrophils, which have neutral-looking granules, eosinophils, which have eosinophilic granules, and basophils, which have basophilic granules. Okay, each of these white blood cells has a very independent function of its own, okay, which makes it very distinct from any of the other white cells. So, your granulocytes, these essentially make up the innate immune system, which I'm sure you are very familiar with, isn't it? So, what granulocytes make up the arm of the innate immune system. They form the first line of defense. And particularly your neutrophils are the cells of your initial immune response. Remember that when you have your total white cell count, we can also have what is called a differential count. Anyone tell us what is a differential count? Differential count is a measure of, okay, if we have these many white blood cells, what percentage of these are neutrophils? What percentage of these are lymphocytes? What percentage are monocytes? Okay, so it is a count of the specific types of white blood cells expressed in percentage. That's what we call differential count. So the differential count, normal differential count of neutrophils is between 60 to 70%. So you can see that they are majority of your white blood cells. Okay. They have a neutral stain, they have granules which have a neutral stain, and they exhibit phagocytosis. Okay, and that's their major function. They are the cells that do phagocytosis. So you see that they will be increased in acute infection. So us who are, you may be coughing right now, we do a differential count, and you will see that your neutrophil count will be raised. Okay. They, physiologically as well, there might be an increase in your neutrophil count in conditions such as menstruation, pregnancy, people that are exercising, you see that your neutrophil count also rises. Okay. Now the thing about these neutrophils is that they have within these granules very potent enzymes. Okay, so such as your peroxidases, your proteases, and the idea is that when they phagocytose a foreign organism, these granules will then engulf these foreign organisms and then digest them. Okay, and that is how these fight off the immune the foreign microorganisms. So other functions of your neutrophils include chemotaxis, opsonization, and of course your phagocytosis. Additionally, you see these neutrophils are also important in the generation of acute inflammatory response. Okay, you see they release these various inflammatory mediators. So what we're saying is that, let's say I'm walking up, I hit my toe against that that tear there, my toe is going to swell up, isn't it? Because of an acute inflammatory reaction, and that is happening again because of my neutrophils, because they are releasing pro-inflammatory mediators, which will then lead to increased blood flow to that site, increased release of painful cytokines, as well as cells migrating to that area, and my toe swell up, isn't it? So they are mediators of acute inflammation. Okay. An increased okay, we talked about what can increase your neutrophil count. And neutrophil count may also be reduced in conditions such as, in typhoid fever, enteric fever, sometimes you can have reduced neutrophil count. Certain drugs can cause a neutropenia. Okay, people that have cancers, okay, they will have a reduction in all cell lines, okay, all white blood cells. So you can see the morphology of a neutrophil. It's the one that's labeled N. So you can see it has a neutral-looking cytoplasm, isn't it? And what's the peculiar thing about its nucleus? Okay, it has multiple segments. Okay, how many segments does that one have? 3, isn't it? You can roughly say that there are 3. Okay, so it has at least 3 to 5 segments. Neutrophils may have 3 to 5 segments. If a neutrophil has 6 or more segments, that's what we call a hypersegmented neutrophil. Okay, so then you can also see your red blood cell in this picture. You can also see eosinophils there with that acidophilic stain on the bilobed nucleus. So let's talk about eosinophils. They have a bilobed nucleus, as we saw. They have acidophilic granules. Normal eosinophil count would be anywhere between 2 to 5% of the differential count. What things will allow your eosinophil count to go up? Let's say someone has an allergy, okay? So these eosinophils, as you learn much later in immunology, mediators of your allergic reactions, okay, hypersensitivity reactions. So the count tends to go up. Anyone has ever had an allergic reaction before? You had. What are you allergic to? Seafood, huh? Okay, so generally, like these seafoods, they're very antigenic. Okay, people tend to get allergic reactions. So when she got this allergic reaction, if we actually you swell up, isn't it? Probably swell up around your face. That's because your eosinophils, they began releasing this chemical called histamine. Okay, what histamine does is that it dilates your blood vessels around the area where these allergens are. That's why you tend to swell up, feel some pain over there. Okay, and if we got her blood at that same time, did a differential count, we see that eosinophils maybe at 30% or something. Okay, because it's a mass production of eosinophils. Right. Now you see, generally, neutrophils, when there's a bacterium that has invaded, they'll be able to ingest this bacterium and they'll be able to phagocytose it, isn't it? Now, what would happen? Let's say you have worms in your body. Okay, let's say you have mice. Okay, this chromosome is too big to be ingested by a neutrophil, isn't it? How can a cell eat something bigger than itself? Right? So it would need to be killed extracellularly. And that's where the role of eosinophils come in. They attack extracellular parasites or extracellular microorganisms such as parasites. So even in parasitic reactions or parasitic infections, you see that the neutrophil count will increase. Okay, eosinophil count, I beg your pardon. So what they do is those same eosinophilic granules that they have, they release them onto the surface of your parasites and destroy them extracellularly. Okay, someone to give us examples of parasitic infections. I've already talked about one, trypanosomiasis. Another one, any parasites that you know. Roundworm infection. Okay, which others? What's the scientific name of these roundworms? You're not doing animal diversity. Neurocytes are they have the least differential count is of basophils, just 0 to 1%. In fact, on a peripheral blood smear, you may not even see basophils unless there's something that is causing an increase in your basophil count. Okay. In what situations will your basophil count rise? Again, in your hypersensitivity reactions. Okay. So they tend to have a very similar function to your eosinophils. Except that basophils are important in your acute hypersensitivity reactions. Okay, so such as anaphylaxis and the like. Basophils again, they may be increased in conditions such as chronic myelitis. But remember hypersensitivity. Have you done hypersensitivity in immunology? Okay, so there are 4 types of hypersensitivity reactions. Basophils will rise in type 1 hypersensitivity reaction. Okay. So then we move on to, you can see this is a basophil, isn't it? It has so many basophilic granules that you can't even distinguish the nucleus from the cytoplasm. Then we talk about your A granulocytes, which are your lymphocytes and your monocytes. Okay? So the lymphocytes, these are characterized, they're very, very classically seen by, you see, a very thin rim of cytoplasm around the nucleus. Okay, so they have a very large nucleus, these lymphocytes, and that's how you tell that the cell is a lymphocyte. However, by looking at the cell, can you tell that this is a B cell and a T cell? Can you tell? You can't, right? Because B cell, T cell, that's a functional classification of your lymphocytes, isn't it? It depends on their function. Okay, you can't morphologically tell a B cell from a T cell. Okay, so they have, yeah, as we said, thin strip of clear non-granular cytoplasm can be functionally divided, and I'm sure you will talk about this more in your immunology. So after neutrophils, these have the second highest differential, ranging from about 20 to 30%. What is the function of your lymphocytes? What's the function of lymphocytes? Remember, we said that when we talk about the immune system, there are 2 arms of the immune system, right? Innate immunity and cell-mediated, isn't it? And innate immunity is, by and large, a function of your granulocytes. Then cell-mediated immunity is a function of your lymphocytes, okay? Of which comprise your B cells and your T cells. Okay. I beg your pardon, innate and adaptive immunity. Adaptive immunity is divided into humoral and cell-mediated. Humoral B cells, cell-mediated T cells. Okay. Yes, and finally we talk about your monocytes. These are your largest white blood cells. Okay, they can they have a kidney-shaped nucleus. Let's see if we have a picture. Yeah, so you can see a bean-shaped nucleus. That's a monocyte. Okay. Now monocytes range on a differential count from 3 to %. They are important. They are important, cells of the inflammatory process. Okay. Now, the peculiar thing about monocytes is that they form what we call the mononuclear phagocytic system. So, what this system is that these cells act like guards. Okay. So they are produced as monocytes, but what they do is that they go into your various tissues, okay, and they sit there, okay, guarding for any reaction that may come. And they essentially form the linking arm between innate immunity and adaptive immunity. Okay, so that's a very crude explanation. You'll probably see details of it in immunology. But yeah, what you need to know is that these cells are formed in your bone marrow, they get in blood, and they sit in your different tissues. They constantly surveil, they form a constant surveillance system in your tissues for any infections that will come. And these cells have special names, right, depending on where they go. Okay, so what are cells of the mononuclear phagocytic system in the liver called? You know this, I'm sure. Okay, Kupffer cells, isn't it? What about in the central nervous system? Microglial cells. Okay. What about in your respiratory system? They are called what? Alveolar macrophages. Okay, or also sometimes called dust cells. Okay. What about in skin? Cells of Langerhans. Okay. And in your various connective tissues, they are called histiocytes. Okay. Of course, a monocyte can mature into a macrophage, which is a generalized name of any cell which will actually form this communication from innate to adaptive immunity. Okay. A macrophage is an antigen producing presenting cell. Okay. Never forget that. Which other cells are antigen-presenting cells? There are only 3 cells in the body that are able to get an antigen and present it to a T lymphocyte. Now, I've told you one is a macrophage. Which one are the other 2? Okay, B cells can be antigen-presenting, and the third one, dendritic cells. Okay, right, that's very good. Okay, right, so that's that. Then this is an RNF counter, so we won't really dwell into it. Let's move on to something important. So, in your short notes, you may get a question. Okay, discuss the functions of white blood cells. Okay, so whenever you get some sort of a question like this, always make sure you first talk about what white cells are, how they are classified. Oh, they are granulocytes, granulocytes. Granulocytes are these ones, the granulocytes are these ones. Then you talk about their functions. Okay. Essentially, we have talked about all of these, right? Because we're talking about the functions of these individual cells. And these few slides will collectively then talk about all of their functions. So let's recap. What are the functions of neutrophils? Phagocytosis, right? Especially acute infections. What are other functions of neutrophils? Come on, guys, let's go. It's the last thing that we're going to do. Platelets, we're going to discuss them when we do clotting. In fact, let's discuss functions of white blood cells. Well, neutrophils. Number one, we said phagocytosis. Opsonization, right? Yes, Doc? Chemotaxis, and hence they help in acute inflammatory reaction, isn't it? They help set up acute inflammation. Okay? What else? Functions of neutrophils. So let's see, we talked about phagocytosis, opsonization, chemotaxis, acute inflammation. Okay. Eosinophils.
Allergic.
They help generate the allergic response, isn't it? 2, they help find what? Parasitic infections. Okay. And okay, on neutrophils, you can even just state that they are important in fighting off bacterial infections. Okay, acute bacterial infections. Okay, let's move to basophils. Hypersensitivity reactions, isn't it? That's where the type 1 hypersensitivity reactions. Okay, lymphocytes, B lymphocytes, what are their functions? There's even one on the board. Yes, this row has been quiet today. We've been talking about this side, this side, this row. So, guys, the functions of B cells. There's one on the board, okay? Yes, antibody formation, okay? So the humoral immunity, okay? So B cells are the ones which will mature into plasma cells to produce antibodies, okay? Lymphocytes, T lymphocytes. What are their functions? Cell-mediated immunity. So these are the cells that will help you fight off chronic infections, right? Chronic bacterial infections such as tuberculosis. Okay, they are also important in fighting off viral infections. T lymphocytes, right? Okay, when you get a viral infection, T lymphocytes are the ones that fight them. Okay, these The T lymphocytes are also important in stimulating other cells of immunity, isn't it? Your CD4 cells, CD4 positive cells will stimulate your macrophages, they'll stimulate B cells, right? So T lymphocytes form a very, very central role of immunity. T lymphocytes are also important in fighting off cancerous cells, isn't it? Your CD8 positive cytotoxic lymphocytes, isn't it? So they are helpful in fighting off cancerous cells. Okay? So you see, that's how you want to think about all of these things. When they tell you write about functions of white cells, don't just categorize functions of neutrophils, not functions of this. You look a bit more organized to your examiner. Then functions of monocytes. They form the body's surveillance system, right? The monocyte phagocytic system. Okay? And talk about how they, from blood, they go and sit in various tissues, always surveilling for foreign antigens and they, sorry? Yes, and they are antigen presenting cells. Understood? And those are functions of white blood cells, and that's where we will end for today. When we meet next time, we will look at blood clotting. Thanks. Any questions? All the best.